Yeah, so Belantamab Mafodotin is a BCMA targeting antibody drug conjugate, and we've really derived a lot of this evidence from multiple myeloma, and we know that's a really effective therapy. Now, we know the differences in systemic AL amyloidosis and multiple myeloma is really largely the burden of disease. Now, in the multiple myeloma setting, there has been a lot of caution and hesitancy because of kind of the ocular toxicity associated with belantamab mafodotin. And again, this is likely related to the regimen, which was initially delivered every 3 weeks. And the doses were quite high. We, again, in the UK, kind of dose modified this regimen. We increased the distances from administration from 3 weeks to 4 to 6 weeks. We were able to, in a large proportion of patients, reduce the amount of belantamab mafodotin that needed to be given, and did find some good positive results. And this is an efficacious regimen. Now, where it fits in the lines of therapies is challenging. So we know that traditional frontline setting, anti-CD38 therapy is important, proteasome inhibition is important. We know that we have access to other drugs, including immunomodulatory drugs. So this is kind of another class of drugs that can be used, and something that we should really think about, potentially down the lines of therapy. So there's not very many, available therapies that show very good responses in our patient group. So it's really important to explore the efficacy of these newer therapies and think really carefully about how we might implement them in the treatment regimen. It's not clear exactly how this will all fit together, but I think our data is promising that there is efficacy. And actually, we found that all of our cases of ocular toxicity in our case series were reversible. So that is a worry that people often ask, I think, in the community. These are severe toxicities. How can we deliver this therapy? But actually, I think in our hands, we found that these are tolerable treatments and demonstrate good efficacy.